Thank you very much. My name is Dalia Said. I work in Nottingham with Professor Dua. It's my first time in India. It's really my pleasure and honor to be here today. So I'm going to speak to you today about conventional and unconventional uses of corneal gluing. So we all know that there are two types of corneal glue, the cyanoacrylate based, which is the synthetic glue, and the fibrin glazed, which is a biological glue. So first I'm going to speak about the cyanoacrylate glue. It hardens by polymerization, so initially it is liquid. Once it gets in contact with tissue, because of the water content, it becomes hard. It has also an advantage that it prevents collagenase activity, so it helps to reduce melting in melting corneas. And it is bacteriostatic against some gram-positive organisms, but not gram-negative, so it can also help in managing the infections. But it is not biocompatible, so eventually you'll have to remove it, or it will fall out, and we will speak about when to remove it later. So we use cyanoacrylate glue in perforations less than 3 millimeters or dismester seals if you think it's going to leak. And corneal melts, also you can use that, and wound leaks. So that's an example of the size of a corneal perforation that you will use cyanoacrylate for. And if you have a dismester seal, and how do you know whether it is leaking or not? You make a very, very thin slit beam, and you can see that the AC is flat, so that's one very good tip. Also, the eye will be soft. And then you put 2% fluorescein. Remember, if it's a diluted fluorescein, you won't see the seedle test, but if you put 2% fluorescein and look with the blue filter, you will see the leak. And sometimes there is a leak and you cannot see a positive seedle test. And that will be because the AC is almost flat, so there is no aqueous to come out. So remember that if you use a soft eye and you see the negative, just press a little bit on the eye and you will see the leak. Because if it's a flat AC, there is no aqueous to come out. So you will not get a positive seedle. And this is an example of a case before doing a therapeutic graft where it had also leaks. And because the eye is so soft, you'll not be able to trephine. So you have to seal the areas of perforation with glue before you trephine because you want a firm globe. And that's then after that we went and did the therapeutic graft. So again, sometimes with these perforations, if it's been there for a while, you can get choroidal detachment. And if you get choroidal detachment, the AC will not form while you're doing your penetrating graft. So in this case, you have to do a little bit of sclerotomy and remove the choroidal detachment so that the AC can form. Again, this patient is a patient with rheumatoid arthritis who's had cataract surgery by one of the colleagues and came 2 weeks later with a central perforation and leak. So remember, with rheumatoid arthritis, sometimes the eye is very dry and you can get from the non-steroidal anti-inflammatory a corneal leak. And this is one of the residents has gone and glued that patient, and you can see how much excessive glue is there, and that she's not removed or only the fibrin or any of the discharge. So the patient had a lot of inflammatory action. Can you see these inflammatory spots after? And we had to treat very aggressively with antibiotics and steroids. And that part remained not clearing at all. So we were thinking, is this infection under the glue that is not throttling? But once we've removed the glue completely, there was nothing, no infection under. So that was just a bit of discharge that was left underneath the glue. So remember always when you're doing gluing to remove any discharge from underneath and around and any epithelial debris, because the glue won't stick and you don't want anything sticking under the glue. Again, if you use corneal gluing in a case of infection, you have to be wary because we do put a bandage contact lens on top, and sometimes your antibiotic will not penetrate very deeply with a bandage contact lens in. So you have to monitor the infection because it can get worse, and if it does, you have to remove the bandage lens. And it's very, very useful to put a very thin layer of glue, and I'll show you how to do that, because if it's rough and you have to take off your contact lens, then the lid movement will dislodge it. So again, this is a seedle positive test, and this is the patient where we put a glue, we put a bandage lens, and look here, the patient developed infection. So you have to really monitor the patients if you're putting glue and putting a bandage lens. So this is what we need to do corneal gluing. We need the spears, we need the cyanoacrylate glue, we need either chloramphenicol ointment or maybe some gel, and these biopsy punches. They come in different sizes. 2, 3, 4 millimeter, and we usually use a 3 millimeter if we're doing a single patch, and then we can use the 3M or any other drape, which is the non-sticky part of the drape. And this is how you do this. These are the biopsy punches. So we take a spear and we cut it. And when you're cutting a spear, don't use a scissor, because the scissor will crush the edge of the spear. So you actually need a sharp blade, so a 10, 11 millimeter or 25 or 15 millimeter blade, and you cut the spear. Then you take a bit of ointment, put it on the top, and you take the biopsy punches and cut the plastic, and you have a plastic disc. So you pick up the plastic disc and put a tiny bit of glue on top of it. And that's an example of the video. Will show you exactly how we do this. So here is the, this is the 11 degree blade, cutting flush and flat the spear. And this is the drape that we use. You use the non-sticky part of the drape. Any drape will have a sticky part and a non-sticky part. And with a rotating movement with your 2 fingers, you rotate the biopsy punch, and you'll have here then inside it the drape, which is plastic, as well as the paper. You don't use the paper, just use the drape. And we put a tiny bit of gel or chloramphenicol just to help you take the plastic and put it on the stick, which is you've created. Then put a tiny bit of glue. See, if you see the glue, it's too much. So if you see blue, it's too much, and you can use the edge of the spear to remove the excess, because you don't want to put excess glue. And this is how we do it. We have to remove completely the epithelium and stick the glue. Again, this is a video to show you this. So I'm removing all the epithelium. Has got to be removed. Any loose epithelium, the glue will fall out. So remember that even if you're making your epithelial defect bigger, don't worry, because you have to remove any loose epithelium. And very quickly you put the glue, and immediately it will start to polymerize because of the fluid inside the tissue. And then you will see the AC forming in front of your eyes, and then you check with Seidel test and put your bandage lens. And this is an example of satisfactory glue application. Can you see this? Just a disc, and the advantage of that plastic disc is that it makes the glue flat on the surface, so not raised areas in between, which will be very uncomfortable for the patient. Like example, this is excessive glue, and you can see the glue is sticking out from everywhere, and that is very irritating for the patient, and you see it will cause a lot of vascularization, as you can see here. So when do you remove the glue? That's the question that we always get asked. So usually by 2 months' time, you start to see vessels coming around the disc and underneath the disc. Once you've seen the vessels coming, you know that the glue is ready to be removed. So what you do is, in your clinic, you take a forceps and nudge the edge of the disc. And if when you're nudging the disc is coming out, then you know the glue is ready to be removed. Then you just hold with the tying forceps and lift the glue, and it will come out. If it's not coming out, then it's not ready to be removed yet. And see here, the vessels are coming underneath and coming around the disc. Then you know the glue is ready to be removed. And then after you remove the disc, sometimes you find an epithelial defect underneath it. Don't worry, because it will close very quickly. And even if it's very thin, don't worry. As long as you have an epithelium on top of the cornea, that cornea is safe. And this is an example of the patient that was being glued. And you can see here it's very thin, but it's epithelialized, so we're not worrying about this patient. Now, what if you have such a big perforation like this? This is too big to glue. But if you have a smaller one with an iris prolapse, then you don't want the glue to come in contact with the iris. So what we'll do is the double drape technique, which has been published by Professor Dua. So here, example where the iris is sticking out from your perforation. Yeah, so what you do is you take a small plastic disc, 2 millimeter, and put it on the iris that does not have glue, and then get a bigger one, which is about 4 millimeter, which has got the glue in it, and stick it right on top. So in that way, the iris is not in contact with the glue. So this is, if you imagine this is the iris, then this is a small plastic disc to cover the iris, and a bigger plastic disc with the glue, which will then seal the perforation but not stick to the iris and irritate it and cause more inflammation. This is a video which will show you this technique. So here, just removing all, see, you can see quite a brisk leak. All the epithelium is being removed. So you can see here, just scraping more and more epithelium. I put some air here to prevent the iris from coming out. Then this is just a small plastic disc without glue, and this is the bigger plastic disc with the glue. And you can see it's very nicely flat on the cornea and very little glue sticking out, and then you can put your bandage contact lens. You can glue at the slit lamp if you're in a busy clinic. I used to do that when I was in Egypt. And here is a perforation that you can see the positive. You can use the sticks, the fluorescein sticks, to show you exactly where the area of perforation, and somebody can help you by just sticking the lids away from each other. And then you can just brush completely, dry completely, and you have to be very accurate if you're doing it at the slit lamp, because when you do it at the slit lamp and if you put excess glue, then it becomes very difficult to remove that glue from the patient while he's sitting. So now we're going to speak about fibrin glue. So the fibrin glue is called the tissel solution. It's formed of two components, the tissel solution and the thrombin solution. The aprotinin is the only component that will prevent fibrinolysis, but at the same time, it can cause anaphylaxis. Very, very rare, but it can happen. And how does it work? So the fibrinogen, which is present in the tissel solution, become into soluble, then insoluble fibrin in the presence of thrombin, which is the other component of the fibrin glue. So it has two components in the presence of factor VIII and calcium. And it appears like honey, so when it polymerizes, it appears like honey, and it hemostatically has the tensile strength of a fibrin clot. So once you put the fibrin glue, it starts to set in 1 minute. You've got 3 to 5 minutes for it to solidify, so you've got some time to manipulate it in the tissue. It reaches 70% in 10 minutes, and it can be full strength in 2 hours, and it's there for about 10 to 14 days. So this is an example where we use fibrin glue in pterygium surgery. So now we don't do any sutures. We don't use any sutures for pterygium. We always use fibrin glue. So here we've removed the pterygium and we've put our marks on the conjunctival graft that we're using, taken off the conjunctival graft, put it on its back, so stromal side up on the cornea, and then we use the thin components. It has two components, thin and thick. So the thin, just few drops, and the thick in the bed. And then, or you can do it the other way around, thick on the graft and thin in the bed. And you have time to flatten it. Use always 2 forceps, tying forceps to flatten it. And you can also use the fibrin glue to seal your tissue. Remember also always to connect this conjunctival edge to the conjunctival graft that you put. And here it takes very, very few minutes and it's all done. And we use this very often in pterygium surgery. No more sutures, no more removal of suture. Remember, the suture is a nidus for inflammation, so it will invite more recurrence. So that's why this technique with fibrin glue has been very useful. And here you can see it's completely 24 hours post. It swells a little bit, then it settles down after the reperfusion of the blood vessels. You can also use fibrin glue when you're doing a multi-layer amniotic membrane. So you put a tiny bit of fibrin between the layers, but that we usually tend to suture the most top layer. And here you can use fibrin glue, very useful in epithelial growth. So this patient had 4 times epithelial ingrowth. So that was the 4th recurrence. And here you can see that we're removing all the epithelium from the bed, as well as from the back of the flap, as well as from the edges, right? Completely remove it. And you can even use vision blue to help you visualize any remaining epithelial cells, and you scrape off all the epithelial cells. Then you put 70% alcohol for 15 to 30 seconds to kill any remaining epithelial cells, and then you put your mitomycin 0.02% for another 12-15 minutes, both on the edges of your bed as well as your flap. And then you put the fibrin glue all throughout the interface, not just at the edge, so that it completely occludes that space that we've created with LASIK. And then you put a bandage lens. And you can see that patients got uncorrected vision of 6.75 post-op with no more recurrence. Also, it is very useful when you have a mismatch between the graft and host. So when you're doing penetrating grafts and you have mismatch between the graft and host, the bed is very irregular and you will get a lot of leaks between your sutures because your host is irregular. And this is an example of a case where the host was very irregular. So I'm taking sutures, and the more you take sutures, the more it will leak next to it. And because of the very irregular host. And more sutures I've taken and replaced sutures and still leaking. So what we did is, this is one more suture I was trying to put. But again, as you can see, more leak because it was very, very thin host. So you put the fibrin glue, the thick component first, and some of it will go into the anterior chamber. Don't worry about that because it will make a little clot, just like a fibrin clot, which will dissolve into 3 days. So don't worry about it. So we put thick, then the thin in the graft host junction, and some of it will go into the anterior chamber. Don't worry about it, but it will seal completely. And then we've used that so many times. Now, if you have any excess threads like this, you have to cut it with a Vanna scissor. Don't pull, because if you pull, you're going to pull the whole glue even out from the graft host junction. So again, also if you have a very thin bed, if you remove sutures, you can still leak from the suture tract. And in that case, you also put fibrin glue and it will seal these holes. You can't really suture these holes. So the only way to actually manage these holes is to glue them with fibrin glue. This is another patient who had a metal injury, and that metal injury was taken out, and then fibrin glue was used to seal the defect. So this is the video. Here is the metal being taken out, foreign body, very brisk leak. So the wound was flushed with BSS, and you can see here very brisk rounded hole. So I think it's working. Oh dear. Force quick. So both the components of fibrin glue were injected in the tract, but it still had leak. So we had to put each component separate in the tract. So you put the thick, then the thin in the tract. It's not letting me. Yeah, there. And again, any excess fibrin you can remove.
Just move on to the next slide, yeah. Or you go out of outside of slideshow and then play. It will probably play.
Okay. Further. There. Yeah. Should I type? So here again, sorry about that. So you can see the foreign body is removed. The wound is flushed and very brisk. Put fluorescein, very brisk leak, you can see coming out from the AC. Always do a paracentesis because you never know when you'll need it. We didn't need it in this case, but it's good to put it. Then we tried with the cannula to inject both the thick and thin components together, but it still leaked. So you can see here there is still leak even though we've injected some fibrin glue in the wound. So then we took a 30 gauge needle and you inject a little bit in the stoma and into the AC, the thick and the thin components separate. So you can see here the thick, then the thin components separate, a little bit into the stoma, and some of it will go into the AC. Don't worry about that. And again, we'll use the 30 gauge needle, which was potentially exactly the same size as the actual wound. Any excess you can cut, and then if you put some fluorescein here, you will see that the leak is completely stopped. And you can put your bandage lens at the end. Okay. Again here, this is a patient post-DSEC. You can see here there is a lot of wound leak and the AC was not taking the air at all. Every time we put the air from the side port, more air will leak from the main wound. You can see here the little air bubbles at the wound. So what we did is we put some extra sutures. Still more leak. The more air you put, the more leak. So sutures didn't work. So then after we did the paracentesis, always good to do that. Then you put the fibrin glue in the edge of your incision and a little bit in the periphery of the AC. And here you can see the glue is being put from the edge of the incision and into the peripheral part of the AC. And then after that, we inject the air into the AC, and you'll see that that it was completely, see the air in the AC is completely taken, and you can also use the glue to cover the conjunctiva. It's not letting me anymore. I think I'm almost done. I've got maybe another 3 slides.
Yeah, because
yeah? It's not letting me. So here also you can use it in managing of leaking blebs. So also in a leaking bleb you can inject fibrin glue at the edge. So the take-home message is that cyanoacrylate is cheap, easy to store, not biodegradable. You have to remove it, and you can use one for multiple patients, not a single patient. You can store it in the fridge and reuse it. But it's irritant, it will cause vascularization, so you can't leave it forever. And the fibrin glue is very versatile, and it is biodegradable, and it's about 70 UK pounds per vial, but you can use it. You can put many cases on the list, 3-4 pterygium cases and amniotic membrane and all, and you can use one for many patients. Thank you very much.